everyone, to RTI International's COVID webinar series. We're glad that you could join us. I'm Linda Squiers. I'm a Senior Health Communication Scientist in the Public Health Research Division, and I'll be kicking off the session today. And it is on knowledge and understanding of COVID-19. I'm also going to be introducing our speakers. First, I'd like to tell you a little bit about the webinar series and the research we'll be sharing. We have planned 4 webinars, each on Wednesday in the month of May on different topics related to COVID-19. The data come from 2 RTI-funded national surveys of the American public. Last week's topic was social distancing strategies. On May 20th, we'll share insights from the national surveys about people's perceptions of their risks and threats of the virus. And our last session will focus on vaccines, including people's intentions and behaviors related to them. Please join us for all of these sessions. After each of the webinars, we will send you the slides in an email. The findings we're presenting today come from both waves of RTI's surveys. The first wave was conducted in late February, early March, and the second was conducted in mid-April. The surveys collected information from a national sample of US residents about, again, perceived risks, knowledge, attitudes, beliefs, and behaviors related to COVID-19. The slide that is before you shows the range of topics covered on the survey and a series of closed-ended questions. We also asked 3 open-ended questions and have analyzed results from those. Today, we anticipate that the presentation will be about 25 to 30 minutes, and we'll spend about 15 minutes at the end of the presentation for questions. I'll serve as our moderator during the question and answer portion of the webinar. We ask that you please submit your questions to our speakers in the Q&A feature on Zoom. And then again, as Shane had said, if you have a technical question about Zoom or your connection, use the chat feature for that. We're fortunate to have an interdisciplinary team across RTI working on a range of COVID-19 issues, including the work you'll hear about today. I'd like to acknowledge that we have a large, full team who's worked on the survey, and representing our team today are 3 presenters, Ms. Molly Lynch, Dr. Jessica DeFrank, and Dr. Lauren McCormack. Molly Lynch is a research analyst and evaluator with RTI Center for Communication Science. Her areas of expertise include emergency preparedness, response and recovery, vulnerable populations, and child and maternal health. Over the past 15 years, Ms. Lynch has conducted communication research on pandemic influenza, Ebola, and Zika. Jessica DeFrank is a health communication research scientist with RTI's Public Health Research Division. Her expertise includes studying patient perceptions and decision-making in a variety of contexts, including cancer and prescription drugs. She also studies best practices for communicating scientific uncertainty to lay audiences. And Lauren McCormack is Vice President of RTI's Public Health Research Division and founder of its Center for Communication Science. Dr. McCormack leads research that bridges the fields of health communication and health policy and develops and tests interventions to promote health decision-making. I will now turn it over to Molly to tell us about today's presentation.
Great, thanks so much, Linda. Today's presentation focuses on Americans' knowledge and understanding of COVID-19. So specifically, we will share findings related to these 4 questions. So first, what does the general public know and understand about COVID-19? And where are the areas of misunderstanding and misinformation? How confident is the public in their ability to protect themselves and their families? And how has knowledge changed over time? As Linda mentioned, we had 2 waves of data collection, 2 surveys. So how has it changed over that time period? And finally, how is knowledge linked with COVID-19 related behaviors? We will provide insight regarding strategies for increasing knowledge and promoting informed decision-making going forward as well. So for this data collection, we used Ipsos Knowledge Panel, and that's a probability-based internet panel designed to be representative of US households. This panel uses an address-based sampling approach to recruit and maintain the panel. RTI developed the survey instrument and conducted the analysis of the resulting data. And as we've mentioned a couple times, we conducted 2 waves of data collection. The first survey was fielded right at the end of February, and the second survey was fielded in mid-April of this year. The data from both waves were weighted to represent the US population. We collected data from just over 1,000 respondents in wave 1 and approximately 2,300 respondents in wave 2. So on this slide, you can see the socio-demographic characteristics of our respondents, and these are weighted to represent the characteristics of the general population, including gender, age, race, and ethnicity. And while this slide shows data for the second wave of the survey, the data from the first wave were similar. So both surveys included a diverse group of respondents. This also includes diversity by education level, which is something that some online research does not always address. In the bottom right corner, you can see that more than 1/3 of our sample were individuals with a high school education or less. We also had representation for all regions of the country and oversampled individuals with Hispanic ethnicity in wave 2, as you can see in the light blue box in the first column. We compiled this timeline to provide context for these data and to remind us all what was happening when. So the tall green bars on this table represent when RTI collected data. And on the left, you can see that our first wave occurred right before a state of emergency was declared and before COVID-19 had begun to make a significant impact on the US. In fact, the first death in the US was reported over the weekend that the wave 1 survey was in the field. The tall green bars on the right side show when we collected our second wave of data in mid-April. In the 7 weeks between the 2 waves, you can see the number of states declaring state of emergencies in the blue bars, and the green bars show the number of states declaring stay-at-home orders. Finally, those red bars are the face covering requirements. Amidst all of this is the national emergency that was declared March 13th, the social distancing order from CDC that was declared March 30th, and the face covering order declared April 3rd. You can see a lot going on. We conducted wave 2 within about a week of CDC updating its guidance about using cloth face coverings when out in public, and after most states issued stay-at-home mandates. Today, we're going to share results from both waves. Now, I will turn it over to Dr. DeFrank to talk about our findings related to the general public's knowledge and understanding of COVID-19.
Thank you. So now I'd like to turn to our findings, but before I do, I'll explain a little bit about how we measured knowledge. We developed a series of survey items within 6 knowledge domains. The first domain is disease susceptibility, or who is at risk for getting disease. We also assessed knowledge about severity of the disease and likelihood of dying from COVID. We asked a series of questions about disease transmission and also 1 item about availability of COVID testing. We also asked about knowledge around protection and mitigation strategies such as hand washing and wearing face coverings. And finally, we asked questions that allowed us to gain a better understanding of where there might be misinformation around COVID. Each knowledge question had a single correct answer and 3 incorrect answers. This allowed us to assess demonstrated knowledge. Each item we developed had at least 1, and in most cases, 2 sources of evidence supporting the correct answer. The sources of evidence were frequently from WHO, CDC, or peer-reviewed studies. Our team monitored the evolving evidence over the course of the time, sometimes adjusting the questions as needed. So before sharing results from the demonstrated knowledge item, I'll start with respondents' perceptions of their own knowledge. So as you can see here, 25% of respondents felt at the time the survey was fielded that they do not have the information they need to protect themselves and their families. This finding suggests that in a sea of information, many people felt that they don't have what they need. Okay, so now we turn to the demonstrated knowledge items. The following several charts will show the percentage of people who responded to each question correctly, which is shown in green, incorrectly shown in red, or with a don't know shown in blue. So the good news here is that there is widespread understanding that people of all ages, races, and ethnic groups are at risk for COVID-19. Only 4% of people did not know that everyone is susceptible to becoming infected. However, we would like to see this at 100%, as everyone should understand this basic and important fact. There was some misunderstanding and uncertainty around the severity of COVID-19. This misunderstanding was particularly high for the first question on the first bar. Only about half of respondents knew that most people who contract COVID only have mild symptoms. Studies suggest that about 80% of people who are not hospitalized have symptoms that could be described as mild. Correct responses were higher, but still not optimal for the question most people who are infected recover from it, with 78% selecting the correct answer. And while 85% understood that the statement most people who are infected with the coronavirus die from it is indeed false, a sizable proportion answered this incorrectly. These findings suggest that many respondents associate COVID with hospitalization or other severe consequences. The communication challenge, therefore, is to balance messaging about the seriousness of disease, which can produce anxiety and fear, with some reassurance that many people recover.
As you can see here, the open-ended responses support what we found from the closed-ended responses, in that the general public had a number of questions about the severity of COVID-19. So this includes how it compares to seasonal influenza and why it manifests so severely in some patients compared to others. People also had questions about susceptibility after you contract COVID-19, specifically if you can get it again, which is not definitively known at this time.
We asked 5 questions related to transmission of COVID-19. Overall, respondents had high levels of understanding related to how COVID-19 is spread, but there are some important gaps in knowledge. In the top bar, you can see that 93% of people knew that the coronavirus is very contagious, and the next bar shows that 90% of people know it's spread through coughing and sneezing. While this is encouraging, it also means that 1 in 10 people do not know this. These are 2 important and somewhat straightforward pieces of information about the virus that we want everyone to know. The middle bar is similar in that most people know that the virus can live on surfaces, but 7% did not know this. And at a population level, 7% is meaningful. Knowledge was slightly lower for questions related to asymptomatic transmission, particularly the question in the bottom row. 1 in 5 people incorrectly believed if you have been in close contact with someone with COVID and don't exhibit symptoms within 5 days, that it's safe to assume that you have not been infected. To the contrary, evidence suggests that the incubation period for COVID is between 1 and 14 days in most cases, and maybe longer for others. While symptoms can frequently occur around the 5th day, it is unwise to become complacent at this point in time.
So this slide shows some additional quotes from the open-ended responses in the survey. And as you can see here, respondents had some questions related to transmission, indicating some levels of uncertainty, including whether the virus was actually airborne, if it could be spread from pets, and if people who have recovered from the virus could continue to spread it.
Some uncertainty also existed related to the availability of COVID-19 tests in the United States. At the time the survey was fielded in mid-April, 40% of those surveyed incorrectly believed or were unsure that anyone in the US who needed a test could get one. However, we know that this is not entirely accurate. In fact, 13% of respondents in the same survey said that they knew of someone personally who tried to get tested and were unable to do so.
We also saw questions in the open-ended responses related to uncertainty around testing. So when asked what their most urgent question related to coronavirus was, participants wanted to know, when will COVID-19 testing be more widespread and available to everyone? when will antibody testing become available, and how to locate testing facilities. And some participants explicitly made the connection between widespread testing and being able to get back to normal.
We also asked respondents questions to assess their knowledge related to protective behaviors. 94% understood that you still have to practice social distancing even while wearing a face covering. However, almost a quarter of respondents did not fully understand the purpose of face coverings, as you can see by responses to the second question that read, wearing a cloth face covering may prevent you from spreading the virus to someone else. At the time that the survey was fielded, guidance had just been released about face coverings, which may explain why understanding was not closer to 100%. But regardless, the interesting point here is that a sizable proportion of people did not understand that wearing a face covering, while it may provide some personal benefit, is primarily for preventing transmission of the virus to other people. We saw a somewhat surprising level of misunderstanding about hand washing. Guidance currently states that you should wash your hands for 20 seconds for it to be effective at killing coronavirus. 44% of respondents thought that washing hands for half of that time was sufficient. Proper hand washing is a critically important prevention practice that may not be fully reaching the American public. And lastly, we found evidence of misinformation around the area of vaccine availability and antibiotics for COVID-19. While 82% of respondents knew that a vaccine is not currently available, almost 1 in 5 did not. There was greater misunderstanding about the role of antibiotics. As shown in the bottom graph, 1/3 of respondents incorrectly believe that antibiotics could be used to prevent infection. And about 1/2 thought that antibiotics could be used to treat the coronavirus. Now, this misunderstanding may have been a result of the news released around the time of the survey about the use of Z-Paks in combination with other drugs to potentially treat COVID, although there does not appear to be robust evidence for its effectiveness.
Some respondents noted the variety of conflicting information, specifically about treatments and transmission, coming from different sources of information, and they had a real desire for definitive answers, as you can see in some of these quotes. As one person says, "We don't know what is really true." I'll pause there, and now I'm going to turn it over to Dr. McCormack.
All right, thank you, Molly, and hello, everyone. As previously mentioned, we fielded 2 waves of data collection, and this allowed us to assess the change in knowledge over time. To measure the change in knowledge, we were asking the same questions at both points in time. So this enabled us to make direct comparisons and look at how the knowledge evolved as the pandemic progressed. So what we did is we created what we refer to as a knowledge index with the 12 items that are shown here. The index is essentially a score ranging from 0 to 100, just like you would get on a test. And I also want to mention that at the end of the survey, we told everyone that the purpose of asking these true-false questions was to understand what Americans do and do not know about the coronavirus. And we explained that some of the questions were indeed false and pointed them to authoritative sources such as the CDC, so that they could understand the correct answers and make sure that they protected their families. As you can see here, the 12 questions span the 5 domains that we've been talking about, including who's at risk, the severity of the disease, how it's transmitted, etc. So we found that knowledge levels increased over the 7-week period that we studied when looking at all 12 of the items combined into this index. So if you look at the bars on the far left, you'll see that the overall average score on the index was 55% out of 100%, and in wave 1, and the purple bar. And then the dark blue bar at 67% is the overall average index on the score at 60 at wave 2. So this is a statistically significant increase. It's not necessarily the grades that you would want to bring home to your parents, but it is trending upward. So if we take that test analogy again, what we're seeing here is out of those 12 questions, people on average were scoring about 6 or 7 correct questions at wave 1 and 7 or 8 questions correct at wave 2. We saw increases in all domains, with some more than others, but overall the knowledge levels were still low in some places. Some of the largest gains were in the area of severity and mortality, which is that second set of bars, moving up from 45 to 62%. We did see some smaller increases in understanding over time regarding how the virus is transmitted. This started out a little bit higher, so there was a little bit less area to gain there. Okay, so we also looked at knowledge levels across vulnerable subgroups to assess what subsets of the population may need to be targeted for public health education. And those with a high school education scored 47%, that's the purple bar on the left, and that's in wave 1, meaning that they answered, again, less than half of the 12 questions correctly. In wave 2, their score increased to 63%, and we also saw some increases for those with higher levels of education, including some college and bachelor's degree, but not as steep of an increase. Okay. Knowledge levels were also lower for those with no insurance or who are on Medicaid, other important vulnerable subgroups. We did see some improvements for these subgroups in particular. As you can see, those with no insurance on the far right increased from 49% to 66%, and then 51% to 69% for those with Medicaid. So trending upward, also still some gaps and need for improvement. The third area where we saw significant increases over time was for minority subgroups, and this is with respect specifically to vaccines and antibiotics. As you can see in the middle bar there, those who are non-Hispanic Black had one of the lowest knowledge index scores across all of the subgroups at 39%. This increased to 51% in wave 2, so moving upward, but still a great need for improvement, and also thinking about mortality statistics for this group, important to make some connections there. Communication campaigns tend to be more effective if they use techniques such as audience segmentation. So when doing communication campaigns, you want to be thinking about the needs of the populations that you're targeting. It's critical to communicate information to these folks in using trusted sources, culturally relevant ways, and using, so for example, when you're thinking about those who are uninsured or on Medicaid, thinking about healthcare providers as an important source of communication as a trusted source. So why is knowledge important? This is the kind of so what question, if you will. What does all this data mean, and how can we use it to help people make more informed decisions about the pandemic? So I'll present a little bit of information next on the relationship between knowledge and protective behaviors. Okay, so we asked survey respondents whether they were currently practicing these 12 behaviors, from washing their hands to wearing a face covering and staying home. And then we created a behavior index, very similar to the knowledge index. It's a nice way to capture a lot of information into one snapshot. So now we have 2 indices. In order to compare them, the one on knowledge and the one on behaviors, we created a visualization and categories for knowledge, which I'll show you on the next slide. So we looked at these 3 categories of knowledge. There were respondents who scored 50% or less on that 12-item knowledge index, and this included 10% of the individuals. And then there were people who scored between 51 to 75% on the knowledge index. This was 37% for a total of just under half of the respondents in low and moderate. And then the balance, or just over half of the people scoring between 76% and 100%, and we classified them as a higher score. So then we looked at how well each of these 3 groups did on the behavior index. In other words, how many of the behaviors are they practicing? And the bottom line here is that the more knowledge that someone has, the more COVID-19 protective behaviors they reported practicing. Those with higher knowledge practice on average 7.6 of the 12 behaviors on the far right in the green, and then on the left you can see those with lower knowledge practice 6.7. So this is an average difference of about 1 behavior per person, which may not sound like a lot, but when you apply that across an entire population of people, when it can make quite a big difference, especially when it's a behavior like social distancing. So we did look a little deeper to see which of the behaviors varied across those with different levels of knowledge, and found that those with higher knowledge, as you can see in the green bars again, were more likely to practice things like social distancing when outside of the home. The green bars on the right also show that people were more likely to be not visiting family or friends and postponing or canceling non-medical appointments or surgeries as opposed to those with lower knowledge. And similarly, we saw those with knowledge, more knowledge, reporting that they're more likely to shelter in place and not let visitors in their home compared to those with less knowledge. So these findings provide some insight into topics that may need more reinforcement in future messaging. Okay, so there's going to be some behaviors that will likely need to change because of COVID-19. Helping people understand why those behaviors need to change can really help them motivate themselves and also potentially sustain those behaviors over a longer period of time. Previous national health education, public health communication campaigns, such as those focusing on HIV and tobacco, have been effective at helping to change behaviors. A similar approach could be taken with the coronavirus. As we go through different phases of the pandemic, people are going to need different kinds of information, and that a public health education campaign could foster that. So we also wanted to look at what was driving COVID-19 behaviors besides knowledge. And these are things listed here. Emotions can play a significant role. What are people's perceptions of their own risk and their family's risk? What kind of work do they do, their family status, their own health status? And then confidence is something we also looked at. We actually saw a quarter of our sample reporting that they were not feeling confident in their abilities to protect themselves or their families from the disease. And this lack of confidence or competency, we often refer to it as self-efficacy, and it's predictive oftentimes of whether a person can engage in the actual behavior. So increasing knowledge is often one way to influence their confidence and their self-efficacy. It's important to recognize the science is evolving, and as we communicate with the public about, we need to explain that, that scientists are learning all the time with COVID-19 and how the guidance may need to change over time. And if we explain this in a way, that can help ensure the credibility of those communicators. So we have a few recommendations we offer and for public health education campaigns. Including, as we alluded to earlier, the importance of understanding your audience, what their needs are, what their information gaps are, so that they can target communications to them. Particularly with when the science is uncertain, it's so important to clearly state what is known and what is unknown at the time of the communication, because when new information is learned, then you can say, we learned this, and now it's something that we are studying, and it looks like the evidence is unfolding. It's also important to cite the data sources to promote that credibility. People often like numeric information. Studies have shown that this is also important to provide qualitative information to help them understand the quantitative information. In other words, explaining that context and helping them interpret the data. And then finally, including calls to action in the messages, helping people understand, what am I supposed to do with this information? And then a few other concluding recommendations here, focusing on the groups at greatest risk, as we saw, and identifying specific knowledge gaps, using multiple channels, including but not limited to mainstream media, as some people may not have access to that. And then evaluating the impact of the campaign over time and adjusting as needed. Having an evaluation in mind early on can help structure and plan an effective evaluation. So I'll conclude with a few summary points. and then open it up for questions and discussion. So as you heard, knowledge was strong in some areas, but yet deficient in others, and there's a confusion that does persist, particularly in areas where there's misinformation, such as vaccines, antibiotics. And knowledge is important and is improving, but more work does need to be done to helping people understand this very complicated virus and disease and how they can keep themselves and their families safe. So with that, I think we'll pause here and ask for any of your thoughts and your questions. Thank you.
Hi, everybody. This is Linda again, and thank you so much for submitting all your questions so far. We've got at least 12 that are in the Q&A, and what I'm going to do is I'm going to read them out loud one at a time and give our panelists or our presenters a chance to respond. So the very first question I have is, are the results published or publicly available? And Lauren, could you answer that one?
I'd be happy to, yes. We are making the webinar slides available to everyone who has registered, so you will receive an email afterwards. And they are not published as of yet, although that is something that we'd very much like to do, and are also working on that as part of making sure that we disseminate the results as widely as possible. And as quickly as possible, it's really important that the information get out there as quickly, thus our webinars.
Great. So the next question is, are you about to look at how information sources of the participants influence their knowledge and beliefs?
Yeah, a good question on information sources. We actually did look at what people report as their information sources, and the leading sources include someone's doctor, which is a common response, and also the internet, not surprisingly, nurses, pharmacists, and then relative friends and coworkers. So one of the things that one could do in an additional analysis is look at how knowledge may vary by people's information sources, and that's something that we have not done yet, but would very much like to do.
Yes, we've had several questions about that. So we do, like Lauren said, have information about where people typically get their information, their health information. We did not ask specifically about where they are getting their information about the coronavirus. And we did not ask about what they do with conflicting information. That's a great question and certainly a worthy question of asking, but that was not one that we included in this particular survey. So here's another question. It's by what I recall of your participant numbers, you had a very low number of minority groups in this research percentage-wise to Caucasian participants. I'm happy to take that one if you like. So the data are weighted to represent the demographic characteristics of the nation. So the numbers, they actually, I wouldn't say are low in particular. They're weighted, they're slightly weighted to make sure that the proportions are representative. So the next question is, were there any significant differences noted across rural versus urban areas or geographic distribution?
Mm-hmm. Yeah, we did start to look at this, and I think at last week's webinar, we actually reported a few differences by region related to social distancing. We have not seen knowledge-related differences by region, and I'll just double check if Carla, you're on, if that sounds correct to you.
That's right. We weren't seeing those regional differences in knowledge that we saw with the social distancing.
Thank you for confirming.
And we have not taken a look at rural urban metropolitan differences yet. That's something certainly we would be very interested in doing, but we just haven't gotten to that at this point. And then I think we've answered the question about subgroup differences in terms of ethnicity, insurance, and age group, if we saw any significant ones. But if any of the presenters would like to add any additional context there.
Now, on age-related differences, that was?
Age, insurance, ethnicity.
Yeah, in the presentation, we focused on the differences that we, on the areas that did show significant differences across knowledge. So that's what we prioritized.
We've also had a couple of questions about the design with the different waves. So these were both cross-sectional surveys. So wave 1 was cross-sectional, wave 2 was cross-sectional. There was no overlap between the samples. Okay. Is there an association with the type of jobs people were working? It may be difficult for someone to say they are sheltering in place if they have to go to work.
Yeah, unfortunately, we did not get down to that level of detail. I do not believe, at least we did not look at it, but I understand your point that certainly could be difficult for someone if their job requires them to go into work. So excellent point, excellent question, and I would like to be able to look at it if we're able to get to that level of detail.
There's also a question if we plan to do a similar study outside of the U.S., for example, in Africa.
Mm-hmm. Yeah, there's been a lot of discussion about whether to do this type of survey, and I think there's a lot of interest in doing this in various geographic locations internationally as well. That is something of interest, and making some international comparisons. So if someone would be interested in a partnering with RTI on that, we'd be very much open to a discussion with you about it. So please do reach out to us, and we can talk with you about that. It would be great to do.
Okay, so we have two similar questions here. One is about medical practices applying the learnings from our survey to attract patients back to their services, since so many are staying away, and also about businesses applying the findings to reopen to help instill consumer confidence in their safety as a customer.
Mm-hmm. Yeah, I think this is a topic of keen interest for a lot of people, of how we begin to go back to some of the things that we were doing before the lockdown. So one of the things I would suggest is looking at where the areas of low knowledge and particularly where confusion were, and thinking about when you communicate with your particular audience, whether it's patients or whether it's employees, making sure that you're providing the information to them, pointing them to these authoritative sources so that they can correct any misinformation. And then again, this gets to the concept of self-efficacy. If once they have that knowledge, they also need the confidence to be able to kind of navigate, ask the right questions themselves so that they can protect themselves. So understanding the needs of the different audiences is step one, and before developing the communications. And then you can also pre-test some of those communications before you launch them with more broadly, whether it's with a small group of patients using qualitative research before you develop any broader messages.
I also have a question that is, did you ask any questions about people who do know about the risk and how to protect themselves but choose not to? Molly, I was wondering if you might want to address this, because I know we have on the 3 open-ended questions that we asked folks, respondents, we did learn quite a bit about their barriers to practicing behaviors.
Sure, and I think we'll touch on this a little bit in next week's webinar when we're looking at perceptions of threat, but we did find some people's resistance to practicing the behavior, specifically kind of thinking that the threat was overblown, that what the mitigation strategies were too firm, and that they were impacting the economy too much. So we definitely saw that, and we'll touch more on that next week.
Great, thank you. Has there been thought to giving a similar survey to this one discussed to healthcare professionals? We would love to do that. And if you are interested in partnering with us in conducting that survey, please feel free to reach out. When you leave the actual presentation today, you're going to get connected to a really quick, just a 3-item survey, and then also you have the opportunity to say, yes, please contact me. If you want one of us from the research team to contact you to talk about a partnership in terms of surveying healthcare professionals, or for us to further analyze data that could help you in your own decision making or development of educational materials and messages, we are delighted to talk to you further about how we might do that together. Here's one more about content. Is there anything in the survey that could speak to the active avoidance or rejection of information?
Not that I can think of. Linda, can you think of anything?
No, we didn't really ask about that. It's such a great question, and that's certainly something that could be asked on a survey, but I think using some other qualitative data collection methods, so we could probe a little bit deeper on why people might be avoiding or rejecting information. Certainly we know that there's denial. Nobody's really pleased with the reality that we're living in, and I think denying some of the risks that are happening is an easy response. I can't say that's anybody's cause. That's just my own personal opinion here. But we didn't really address that in the survey. I'm going to ask one or two more, and then I think we'll wrap it up. I did say it would take about 15 minutes of questions, and we do try to end before the hour is up. And did you have an opportunity to look at the differences in the 2 indices developed by region?
So this one came up a little bit earlier. We did not see any differences by region for the knowledge index. One of the things we could look at is urban-rural, and we can do that.
Okay, boy, we're getting lots more questions in. So curious, did you ask the respondent if the respondents had themselves received a positive COVID-19 diagnosis? I guess with 2,000 respondents, you might get 100 or so positives. If so, how did the positives compare to the national infection rate?
We did ask this question, and it was a relatively small amount of people who said that they received a positive COVID test themselves. We also asked whether it was their family member, a friend, a coworker, someone else in their household, and the percentages were generally less, in and around 10% or so that we could work with there, but nonetheless, we could elaborate more on that data. We also asked if people had symptoms, whether they received a negative COVID test, whether they've been hospitalized. The numbers were a little bit lower when you get into that, and whether they knew someone who had passed away from the virus. So we do have a little bit more information that we could look at for those perspectives. We are very much interested in getting into that and comparing that with knowledge. So there's a lot that could be done with the data that we would be interested in working with folks to do that. And now that we have 2 waves done, this is something that could go on over time, certainly as the pandemic progresses and new information needs emerge, to be able to monitor the pulse and be able to respond accordingly with credible information to the public that meets their needs.
Okay, so we also have some questions about how far we can dive into, like, looking at differences between states or other hotspots. So that's, we would love to be able to do that as well. For any individual state, our sample size is really fairly small, and we don't have data weighted to be representative of individual states. That certainly can be done. We can do surveys like that. So if you are from a state and you're interested in doing that kind of survey to do an assessment of your state at a given and any individual time or over time, please contact us. We can work with you.
Mm-hmm.
And there's so many. Boy, I think it's more than we're going to be able to answer. One thing that was also asked about was whether or not we gave people proper information at the conclusion of the survey, and I can answer that yes. We definitely made a pretty clear statement that some of the, especially on the knowledge items, that some of the information was not accurate, and directed them both to the Centers for Disease Control and the World Health Organization sites to get the accurate information. So we made it clear that everything that was in the survey was not factual, that we were asking them about their knowledge. All right, so there are a few outstanding questions still. We do have a methods document that is on our website that, after our webinar is over, you can go back to where you registered at the website and you can pull that. So that should answer many of the questions that you do have about the methodology that we have used. So if there are some burning questions that we haven't answered, feel free to email us or contact us through that contact button as you exit the webinar today. Again, we'd love your feedback on the webinar, so take that 3-item little quick survey, and then that's also the place where you can put in your contact information. So if I haven't gotten to your question so far today, please just let me know, and I'm happy to email you directly or give you a call. Any final words from any of our presenters today?
No, we just thank everyone for joining. We appreciate your time and look forward to connecting with you soon.
Everybody had great questions. Thank you all so much for your participation, and have a wonderful afternoon. And we hope to see you here next week for our 3rd webinar. Thanks, everybody.